On behalf of Learning General Surgery, I welcome Ashwin, Dr. Rajesh, and Dr. Sanjay. Welcome, sir, to this platform and to the very interesting series of liver transplantation by Ashwin. And he's been doing every Friday for the last about 7-8 Fridays, I believe.
Absolutely, sir.
More. And
about 2 months now.
I hope he'll continue for eternity. There's so much to discuss. And anyway, welcome all everyone, and over to Ashwin.
Thank you for that introduction, sir. So, welcome once again to another session of the liver transplantation series on the LGS forum. After speaking about disease donors last week, we will now go on to LDLT donor evaluation, the operation itself, and of course, what lies in the future for this operation. Now, the two basic founding concepts of LDLT include ensuring that donor morbidity is kept to the minimum and that recipient outcomes are not inferior to a full-size DDLT itself. And unlike DDLT, LDLT is a directed organ donation, and a clear judgment is needed to balance the donor risk on one side and the recipient benefit on the other. So this is called the ethos of double equipoise. However, it is also sobering to appreciate that it may never be possible to completely justify a surgery which violates the core medical principles of above all do no harm, which means that despite taking every precaution, even in the most experienced of hands, donor complications may be inevitable, and this remains the single biggest deterrent to performing LDLTs. Hence, keep the risk to the lowest possible level, protocol is imperative, and all large volume centers have a strict algorithm for this, which is remarkably similar across the world. The aim is to reveal pathologies that could increase the risk of complications in a healthy donor while excluding an unfit donor at an early stage. The donor operation, hence, is also very crucial to the safety, obviously. And the success of this surgery is important for the transplantation and for the surgeon, and most importantly for the transplant program itself. And each step is measured and a calculated one. It's usually the best surgeon in the team who performs this operation. To speak to us about all this is our first esteemed speaker, Dr. Rajesh Rajalingam. He is a transplant surgeon with Professor Ella's unit and has been part of the team for a decade now. Rajesh is also the clinical lead for HPB surgeries and is the main LDLT donor surgery, having performed over 500 of this operation. He has now subspecialized into robotic donor surgeries as well. Apart from his many traits, Rajesh has a tremendous ability of reading and visualizing CT scans, and his anatomical acumen is noteworthy. It's no wonder that Prof finds him to be the best surgeon in the team and sometimes even better than himself. Apart from his superior surgical skill, what impresses me personally is that Rajesh has an ability of making fantastic PowerPoint presentations and evidence-based arguments on absolutely any medical topic. A very affable person and teacher, Rajesh is also known within the team for his sporting skills and its related injuries. Now, it's quite common and fashionable in all these surgeries these days to do it laparoscopically. And the question arises, why not laparoscopic donor surgery? But here, safety comes first, like I mentioned earlier. Along with the fact that the liver graft cannot be squeezed and crushed out of the donor's abdomen through a tiny incision like a gallbladder, which leaves the question, is minimal access surgery really indicated and safe for live donors? To speak to us about all this is our next speaker, Dr. Sanjay Goja, who heads the transplant services at Narayana Hridayalaya across the country. Goja he's affectionately called, trained in Delhi at Gangaram Hospital, followed by a long stint at Medanta as an integral cog in Dr. Soin's team. He has done over 1,000 donor operations. I know Goja for almost 2 decades now. He was my SR in Gangaram, and we have shared a very special bond since then. He is one of the sweetest person you can ever meet and has been a role model for many, including me. A very quiet, hardworking surgeon, he has been the backbone of many successful transplant programs, and his surgical skills and knowledge have to be seen to be beat. Goja will speak to us about the future of donor surgery. The floor is yours, Dr.
So,
If you can share your slides, yeah.
Yeah. You can see in the slides?
Yeah, that's visible.
Okay. Thank you, Ashwin, for the kind introduction. And thanks to Pata sir as well as the Learning General Surgery Group for giving me this invitation. So going into this topic, living liver donor evaluation and the operative steps, this topic is very close to my heart. There is a unique thing about living liver donor evaluation. This is compared to any other evaluation. This is unique in sense these are not patients. The donors are not patients. They are actually volunteers. They are different in one sense. They come into the hospital not because they have some illness. They come into the hospital because they want to cure somebody's illness. Second, they have just made a decision to go ahead with the donation. So it is the responsibility of the transplant team to take them ahead in making them understand not only the medical part of it, but also they need to understand actually the realistic chance of their liver donation, especially the right lobe donation, which is a major operation, realistic chance of having a mortality, as well as to know all the facts, including the success rate of this operation for the recipient as well. They need to be completely aware, and the most importantly, at any point during the time of evaluation, they should be given, and this point has to be stressed that at any point of time they can come out of this donation process, and it's a voluntary thing. So this plays an important role in the team that evaluates the donor. And most importantly, I would say that the medical legal aspect of one second. There is some issue with most importantly, the medical legal aspect, I would say that this has important implication. For example, a donor death in US, where the LDLT was growing up, they had a mortality in 2001, which pulled down not alone the team, the institution, but the whole nation, which is reflected by the next year, where the number of LDLTs performed in US came down to halved actually. Can I take a minute? I just leave it. Okay, thank you. So this is what I was talking about. It is half. So this is very important in terms like when a living donor, like when you are dealing with a living donor, especially the liver donor. So going to the evaluation, only two things that we actually take into that we actually look for. One is especially the right lobe donation, whether the patient is fit enough to undergo this major operation, whether they are healthy, to confirm their healthiness, as well as whether the liver has the capacity to grow back and the liver that is going to the recipient is healthy. So these are the two aspects, broad aspects that we look into. This is a paper which tells about from SNUH Korea, where almost 728 donors were evaluated, and out of 726, almost half of them didn't undergo donation. And the reason for that is, apart from the recipient, which reasons, which is 20%, the donor reason amounts to 30, and out of this, not willing to donate fatty liver and a low remnant volume are the reasons for not going ahead with the donation. So the evaluation process basically has to define all these things. So every unit has a set protocol how they evaluate the donor. We have the first interview with the surgeon from the transplant team, then the first set of labs, basic labs, which assure that they can undergo this major operation, Ctn Mri for liver assessment, and further consultations. So the first three steps basically filter out whether the donor will be able to donate or not. The minimum criteria for donation, according to our transplant law in India, they are defined as near relatives. That is, the first degree relatives, including the spouse. They are they are called as near relatives, and there is no need for them to go to the authorization committee. The hospital itself can actually authorize them to go ahead with the donation. Anything out of this, even uncle, aunt, and anybody out of this, they have to go to the authorization committee and then get cleared. They are ruled out of any coercion, financial reasons, all these things. Then they have to get the authorization committee clearance. Second broad is the ABO compatibility. Even though, having said that, there are certain groups where like ABO incompatible transplant is also possible, but in general, it has to be ABO compatible unless until there is no other donors available in the family. Age-wise, the legal limit is 18. The biological age the upper limit has been taken as 50 because to have a retained regenerative capacity of the liver. And BMI of less than 30. This is a surrogate marker for fatty liver basically. And obviously no chronic illness like diabetes or chronic coronary artery disease, which has a significant impact on the outcome of the surgery. So the first visit for the donor surgeon with the donor surgeon is very important, that he has to be an experienced person in the team to handle and take them through all the questions that they want to be clarified. You also need to understand the recipient and the family dynamics involved. Apart from that, he has to get the routine history to make sure that they don't have any chronic liver disease or any chronic illness in the past, drug allergies, any previous upper abdomen surgeries. And at the end of the discussion, they need to be aware of the realistic chance, like mortality of 1 in 300, the world quoted rate, the literature quoted rate in right lobe, and 1 in 500 for a left lateral segment donation. They can also be offered a second consultation and a one-to-one discussion. We feel that a one-to-one discussion with the donor, not with the recipient family, has to be done to rule out any coercion involved. And the best way actually to help them, the donor, to alleviate his anxiety is to let them meet one of the previously donated donor in the hospital to interact with them. So the first stage of investigations, as I said earlier, you have to confirm the blood group. These are the red ones are the one that can alarm the team regarding the possibility of reasons that they can reject. One is liver function test. Not only fatty liver, the transaminitis can indicate that they can have a fatty liver along with the inflammation that's called as NASH. And any reason for elevated bilirubin has to be found out. And the type of bilirubin, whether it's unconjugated or conjugated. Unconjugated bilirubin is usually not an issue, but they need to be evaluated to find out that to make sure that they don't cause any impact on the donor surgery. And HbA1c for relatively older donors, make sure that they are not borderline diabetic. Lipid profiles, especially we found that triglyceride, serum triglyceride is of very use. And this study from Korea mentions that age more than 30, BMI of more than 25, and triglycerides more than 150 actually are good surrogate markers to rule out patients who have a moderate or severe fatty liver. So going to the next stage is Ctn Mri. These are done together. I think they are complementary to each other. One of the most important thing is they are done first to make sure that the volumes are okay and to assess the vascular anatomy, including the biliary system and other like fatty liver, any other issues like fibrosis or any other organ abnormality which can have an impact on the donor surgery. The CT that is done is triple phase CT, but it is not the same CT that usually we do for evaluation of a liver lesion. Because especially the last phase, the hepatic venous phase, is usually done to delineate the hepatic veins, whereas in a lesion, it's parenchymal phase where most of the contrast is washed out. You need to have a very thinner cuts rather than the thicker ones. It has to be minimum of 0.6 to 1 mm because it helps in reconstruction. The patient has to be hydrated well. So the first thing I'll talk about is the volume. So the volumes are measured by drawing the lines around the part of the liver, excluding the veins, extrahepatic. So in volumes, we are talking about two things. One, like we take the total liver volume and the graft liver volume. Usually in adult, it's a right lobe. So once we have done with this, we go to we are evaluating two volumes which will be important for the selection of the donor. One is remnant liver volume. If the remnant liver volume is more than 30%, actually he is good to go because the limit has been set as 30% because 30% has the capacity to regenerate and not having any impact on the liver metabolic demand in the post-op period. So there are situations where there are less than 30%, but there are other options are available, which I will discuss later. So once you are happy with the donor, then you worry about the recipient, in sense graft volume. So graft volume, you need to find whether they are adequate for the recipient. There are two ways of assessing it. One is GRWR. That is, they based it either on the recipient body weight or the standard liver volume of the recipient, which they calculate by formulas. What we usually take is the GRWR, which is the lower limit of the GRWR that we actually accept is it should be 0.8. The volume has to be 0.8% of the recipient body weight. If it is anything less than that, we have to reconsider. For the standard liver volume, it has to be more than 30 to 35% of the standard liver volume. So each unit has a different assessment, adequacy assessment. We take GRWR. Now, in the recent times, the lower limit has been reduced to 0.7 because of a lot of portal flow modulations and the understanding the age being important factor. There are many important factors which can help in the help in reducing this limit to 0.7. What you need to understand, there is a correction factor of 10 to 15%. So on papers before donation, they have to be a lower limit set at 0.7. If not, better to have some other donor evaluated. So there are various methods of assessing the liver volumes. There are softwares available, MRI also coming into the picture. So we will see it in the future. So once we have the liver volumes, we will need to select the graft. So this is an approximate idea what I want to give. In a pediatric age group, the required GRWR is about 1 to 1.5. So usually left lateral or the left lobes are donated for pediatric patients. So if you take an average left lateral segment, let's say it's 200 grams, 50 to, like the recipient weight can be up to 15 to 20 kilograms for them to donate their left lateral segment, which is about 25% of the total liver volume. Whereas when you take it to adult, which is usually the right lobe, if we take a right lobe volume, average right lobe volume of 650 grams, I have taken the lowermost average, 650, and if the GRWR, like the lowermost GRWR is 0.7, you can actually get them donated up to 92 kilograms recipient. So that's a maximum recipient weight that you can take. This is to have a gross idea. So how to tackle this inappropriate volumes, for example, insufficient remnant liver volume for the donor, they can go in for assessing the left lobe, whether they have a good GRWR, or even the right posterior sector need to be assessed. In case of pediatric, it's never an issue of remnant volume. In an adult, for the graft volume, if it is less than 0.7, there are also options available where they can actually assess the donor recipient matching. For example, a very young donor donating to a very low MELD patient, and with advancement of understanding the portal dynamics, actually you can, in few patients, you can shift the lower limit. As well as dual graft is an option which is common in Korea. Other options are swap transplantation, like when volume swaps that can be done. Pediatric is usually lands up in large for size graft, and they have either hyperreduction or a monosegment. So all right posterior grafts are not donated. They need to have a favorable anatomy, in sense they have to, the right posterior portal vein has to come up early from the main portal vein. The biliary anatomy also has to be single, and it is usually better to have infraportal rather than a supraportal, because results have shown that they have a higher incidence of biliary complication. And the transection plane also, the venous tributary is much more than actually the portal drainage, and they actually land up in having more ischemic area. So once the volumes are done, assessing the vascular anatomy, CT, we need to make sure that first let me go to the artery. Out of the 4 evaluated, like artery, portal vein, hepatic vein, and biliary, if a donor can, because of an anatomical problem, it's usually because of an artery and a portal vein, not because of hepatic vein or bile duct in the current scenario. So hepatic veins, we follow the Michel classification. 1 and 2 will have variations. We need to understand the variations. It is okay to accept up to 2 arteries in a graft. More than that, we reconsider. Obviously, I think most of the time we reject and look out for another donor. This is an example where right lobe has 2 arteries, one from the GDA and one from the left hepatic artery. And this is a video which says there are 2 arteries in the graft, and you can see a very good backbleed from an accessory small artery. This is a situation where we can actually ligate the accessory artery and move ahead. This is another scenario where actually there's a single right hepatic artery, but it is bifurcating to the left of the bile duct. It's called arterial girdle. We call it arterial girdle. And because it's an equal size, it has to be reconstructed in the recipient. So coming to the portal vein, we follow the Nakamura classification where type A, B, and C are usually favorable, like they are okay to donate. Type D and E are usually contraindicated. The reason is type D is you have an intrahepatic origin of the left, like anterior sector portal vein. Not because of just this, usually they are associated with left-sided gallbladder, biliary anomalies, which are very difficult to understand, and actually the remnant volume is also low in these patients. So for a right lobe donation, they are not acceptable. And type E anatomy, single trunk coursing throughout the liver parenchyma, you will land up because you have to reconstruct the donor portal vein, which you are putting the risk, transferring the risk to the donor, which is not acceptable. Another thing about this is the type C anatomy, which Dr. Sanjay Goja should be talking about. It is not a favorable anatomy for a minimally invasive donor hepatectomy. So going to the hepatic vein. So as I said earlier, there is usually donors don't get rejected because of hepatic vein anatomy. But what is important about in a right lobe donation in hepatic vein is right hepatic vein drains the right lobe, that's fine. But middle hepatic vein drains both the right lobe as well as the left lobe. So how to deal with middle hepatic vein is usually the question. So to tell you about a rough figure, out of like right hepatic vein becomes a dominant drainage of the right lobe in almost 40% of the patients. And right and middle are equally contributing each other in another 40 to 45% of the patients. The rest 5 to 10% will have the middle hepatic vein dominant. So in these 5 to 10, obviously we have to somehow get the middle hepatic vein. Either we have to look out for the donor remnant volume, the donor age, and the presence of fissural vein to make sure whether we can take the middle hepatic vein, or we have to reconstruct the 5 and 8 separately. So recipient factors also comes into the picture. In rest of the case where the right hepatic vein is dominant, we need to assess the size of the 5 and 8 to the donor age and the remnant to make a decision whether to reconstruct it or not. As a rule, we have moved to a point where we don't take middle hepatic vein by default unless until the situation demands or it's favorable. For a left lobe, obviously left hepatic vein and middle hepatic vein are taken together. In a left lateral segment, there are situations where the segment 3 vein drains into the middle hepatic vein instead of forming a common trunk with segment 2, where you have to reconstruct it. This is a picture where you have a very good fissural vein. So the donor age was low and they are good remnant, and we had to take a middle hepatic vein along with the graft. There are centers who take routinely 2/3 of the middle hepatic vein, like Hong Kong. Other venous drainage, that is inferior right hepatic vein. It plays dominant role in almost like 5% of the patients. It is much bigger and more than the right hepatic vein. In these situations, you have to give due consideration for reconstructing the right hepatic vein. But in general, as a rule, more than 6 millimeters of inferior right hepatic vein, we have to give due consideration for reconstruction depending on other factors as well. So this is a picture about how we reconstruct the segment 5 and 8 tributaries. Coming to the biliary system, MRCP, preoperative MRCP, we in our unit consider it as one of the most important, and we are happy that our MRCPs are of very high standards. And you have to get your, apart from the primary biliary confluence, you have to get your second order ducts well visualized. When we can call MRCP quite adequate in sense is, If your right posterior entering the confluence, where primary biliary confluence is visualized, and in the left side, if your segment 2 vein, segment 2 biliary system entering the biliary confluence. If you can identify these two things, I think what we believe is there is no need of intraoperative cholangiogram, but that is not the standard. Let me take it in the next few slides. So biliary duct classification, we follow Huang's classification, where they basically described based on how the right posterior enters the biliary system. What is important here is there are two types, like type A and type A2 and type A3, where they have a supraportal course. The right posterior have a supraportal course, which has shown to, in studies to have a higher biliary complications. But definitely we don't differ them. Like we deal with like hepatic jejunostomies and where the results are good. For the left side system, it is based on segment 4 entering the left hepatic duct, and we follow the Okuba system. So apart from MRCP, we use like standard ways to use intraoperative cholangiogram during the time of surgery to assess the biliary system. The routine is to have 3 times done. One is baseline before to find out the area of duct division, and third is to have a completion cholangiogram. So this is a routine. We followed it until 2014, but no more after that. Let me discuss during the time of operative steps. So once this vascular anatomy is done, we go to the reasons for exclusion. As I said earlier, 8 to 30% of the donor exclusion because of the fatty liver. Why fatty liver is a problem is, one is it impairs hepatic regeneration. Apart from that, it increases surgical time, and even the DDLT setting, it has been very like known reason for a primary non-function. The acceptable limit in a living donor setting is up to 30%. Up to 30% is the maximum, not like your DDLT graft. Most of the centers accept less than 10% cirrhosis, but there are centers which accept more than that, but after donor optimization. How to assess this fatty liver? The easily available one was the CT scan, that is during the plain CT abdomen. We assess the Hounsfield units of this liver. So as a blanket statement, liver Hounsfield units, if it is less than 40, actually the patient donor has a high chance of having more than 30% steatosis, and thereby itself you can actually stop the reevaluation and then move to the next one, or donor optimization. So the ideal LA that we are looking at is LA is liver Hounsfield units minus the spleen Hounsfield units. We are looking at is +5. Our protocol, if it is more than +5, it's good to go. The reason is, if it is more than +5, it has almost 100% accuracy that the donor is having less than 10% steatosis. If it is less than -10, they are completely not suitable, and there also recent studies have showed that it is the possibility of having it more than 30% is almost 100%. So if a donor has a LA between +5 to -10, then we move ahead with further optimizations or further investigations. How this LA is calculated? Every 5 centimeters, you have a region of interest taken in the liver and then average it. This is how it is done, like 5 readings in liver every 5 centimeters and spleen and average it out. So as I said, LA, though between 6 to 30% steatosis is not accurate, but it has a very high negative predictive value. Current modalities like MRI, including MR spectroscope, has been found to have very like almost obviating the need for a liver biopsy. And here the proton density fat fraction study has shown that it can exclude the presence of hepatic steatosis more than 10%. Obviously, so currently there should be no liver biopsy done for donors who are for the reason of fatty liver. So where the liver biopsy comes into the picture, okay, not fatty liver, but if there is any enzymes alteration in the form of transaminases, then obviously NASH cannot be picked up with imaging. So they have to have a biopsy. Or when there is 2 or more risk factors during the time of evaluation, it's always better to have a biopsy, and there is no replacement for that. So after completing this step, they go to the almost here we would have decided whether the donor can go ahead or not, and then they go to the donor advocate. and psychiatric evaluation. Donor advocate is a person, is a physician who is completely independent from the transplant team and assess the donor, hear from the donor any issues with he or she having problems with the donation, and then he advocates for that. So and the rest of the evaluation like cardiology, gynec for women, and the consultations. So the last what we do is the final set. This is a costly bit of the donor evaluation, and this they look into the specific liver pathology and coagulation issues that can have an impact on the donor surgery, autoimmune profile, thrombophilia profile. We had a patient who came from Middle East, transplanted Middle East, and actually after the surgery, both the donor and the recipient had portal vein thrombosis and artery thrombosis, and it was found to have a homozygous factor V latent mutation. So it is very important to evaluate for that factor C, protein C, protein S, factor V latent, antiphospholipid, the hypercoagulable states, and G6PD status because many of the Middle East patients has this abnormality, and for Wilson's serum ceruloplasmin on 24 hours urine corpus. So once this is done, they go through a pre-transplant meeting and a video consent is obtained along with the documentation. So this is one of the largest living liver donor study published by SNUH in the Korean registry, and they found that out of the 53 donor deaths, most of them are suicide, traffic accident, few more. So it's important to understand the psychological part of these patients, and actually when everything goes well, actually they feel more positive, but something happens to the recipient or even them, actually they have a big psychological impact on the future life and the quality of life. So moving to the next one, operative steps in donor hepatectomy. I had a video here. I'm not sure whether it will run, like I'll try. These are from different donors, not a single donor. So we started with reversal incision, and we now moved to midline incision. The problem with midline incision is the midline incision, when you have two portal veins or IRHVs, significant IRHVs, where we have to have multiple clamps applied, then midline and taking a large liver graft out of a midline incision, sometimes it will be very difficult, and you have to be prepared for those situations. So once we are done, we mobilize the liver, then we do the cholecystectomy. So once the cholecystectomy is done, in this video, obviously when starting we have to confirm the liver quality is okay, and then we have to give a go for the recipient to be shifted. So then the KY is mobilized after right lobe mobilization, and the caudate veins are taken down and secured as well with a suture. Here there is an inferior right hepatic vein that is mobilized, and the right hepatic vein is ready for looping. The space between the right and the middle hepatic vein is opened out well, and we have the KY is we have looped the we have get the sling for the hanging manner. This sling helps not usually for during the time of transaction, not for the first half, that is still segment 5 vein, but later half for the segment 8 vein as well as the caudate, it helps. Then coming to the hilum, we get the traction on the cystic duct actually helps in getting your portal vein as well as your artery mobilized without any difficulty. So here we can see all the anterior, posterior as well as the left. Here the caudate vein is looped and then tied. Sometimes these caudate veins are big, and you have to be careful in suturing it, and if it slips, it can cause bleeding, and it can tear and the tear can go into the main portal vein as well. You have to be cautious about that. So here the right portal structures are looped. Once done, our routine is to do this is a clamp test, right? Portal structure clamp test, where you have the demarcation, and then we measure the baseline portal pressure by putting a needle into the portal vein, and we accept usually the portal pressure comes. It also depends on CVP, but it is around 5 to 8 or 9. I will talk about it when we actually don't. Our worry is when it is more than 12, 13, we need to actually look into many factors, whether is there any issue or really the liver is a problem. So going into this, let me stop here. As I said, intraoperative cholangiograms. Intraoperative cholangiograms are, we have a selective policy. It's not that we don't do. When our preoperative imagings are not good, actually we go ahead doing MRCP. Sorry, pre or intraoperative cholangiogram. The thing about intraoperative cholangiogram is, you have to get your angle right, because the primary biliary confluence is at a 20 to 30 degree to the right side. So you have to get your table up 20 to 30 degree, head down, and so that the primary biliary confluence is well seen. And it is a 2D image, and it requires a lot of time, and there is a theoretical risk of pancreatitis in this case. So this is our protocol, but the standard of care in all the institutions till now actually is to do a intraoperative cholangiograms. So once we are done with that, we mark the demarcation line. So here we use we have taken a bite on both sides and then ready for transection. This is a CUSA. We use CUSA. There are people who use for water jet also. This is a CUSA which has a monopolar diathermy in it, and they have amplitude, irrigation, and suction. So we have a standard setting, and we find that it is faster than water jet. Though we have not much of experience with water jet, we heard that it is actually much faster than, and we are trying to get this in our minimally invasive hepatectomy as well. We found it to be much more comfortable than any other energy source. So here the portal structures are usually pearly white, whereas the venous structures are bluish in color. Here this is a point where, like this, here it's of a segment 5 vein that is not big size. It is probably less than 5 milliliter, which is being looped. So when you actually do the transection, if you want to find out how significant V5 or V8 in like whether we have to reconstruct is calculated as, if you want to see the area of congestion, what we need to do is you have to put a clamp on this segment 5 vein and put a bulldog on the segment like right hepatic artery. What happens during the time is the only outflow for that particular ligated, like blocked area is the portal vein. So literally that segment will not have any blood flow except the any blood flow into it. So it becomes more duskier. So the area is well delineated. So that's how we assess the size of that area, whether it requires reconstruction or not. This is a arbitrary method, but we find that very useful. Oops. It's coming as missing file, is it? Okay. So segment 5 is done, and here we have come to segment 8. This is a good size segment 8 vein which requires reconstruction. So here we got our sling, and we work below the sling. Sometimes we take the segment 8 also if it's small in size, because it is big in size and two coming together. We thought we will take it at the time of graft harvesting. So there are various ways of securing the structures. We use clips. And here the chordate, once the transection is done, the chordate is done, and the bile duct, we first give a cut more to the right side, and then we probe it, and then we move ahead. So once the duct is done, the hilar plate, which is very vascular, is divided and then sutured under vision then and there. Because if you leave it to the end, they can actually go for spasm, and then they can bleed in the post-op. So we have to be very careful about the hilar plate. So now it's ready for harvesting. So the right hepatic artery is now ligated. The point here is, in this video is, when we put a clamp on the right portal vein, you need to make sure you see the left side, especially the point where the main portal vein goes into the left portal vein. That point needs to be assessed before actually you apply the clamp. And then in this case, there is IRHV. We usually take a marking stitch on the inferior aspect of the vein to help in reconstruction. So IRHV is taken down, and then the RHV here, actually there are two veins coming to form an RHV. That's why the clamp is a bit bigger size. You have to be careful about the Ctn. You have to make sure your Ctn works well before you actually use it. So this is here. This is another one where it's a left lobe being harvested. This is an accessory vessel. You can see a good back bleed in the accessory vessel going to the left gastric artery. That is a vessel coming off from the left gastric artery. So once we assess that it is a good size vessel, like good black bleed is there, then there is no need for reconstruction. Our policy is not to reconstruct. Here's the left portal vein. And in this case, left side veins, you have to have the diaphragmatic veins off so that you have enough space to go and get a common trunk of the left and the middle hepatic vein. So this is just to show you the left-sided organ retrieval. So I think these slides I kept it in case my video is not running. So the after the surgery, actually we take almost like 30 minutes or so in making sure that all the vascular structures, including the small caudate veins, the IVC are sutured, ligated, and the hilar plate is run posteriorly from the point of bile duct, and they are secured and then fixed as well. So this is two pictures are very close to my heart. The first one is in February 2016 where I finished my first independent donor hepatectomy, and the second one is the person who gave me this opportunity. Thank you so much.
Excellent talk, Rajesh. It was quite comprehensive with regards to how you go about choosing the donor and the operative steps as well. Very vivid. If you can have Dr. Sanjay Goja to give his talk, and then we can go ahead onto the discussion part of it, which I'm sure is going to invite a lot of questions. Dr. Goja?
Yeah. Can you see my slide, Ashwin?
Yep. Yes, Goja. If you can make it full screen, then.
Yeah, I'm ready. Yeah, is that okay?
Yeah, that's
is that
good.
Okay?
Yeah, that's good.
Yeah. Thank you, Ashwin, for giving such a nice introduction of me. I didn't know I am such a nice guy. Thank you very much. So you have given me a very difficult topic. Although I do robotic hepatectomies, I do robot donors also. But the question is whether it is a future and should it be followed. What we have to understand, as Rajesh told, the primary prerequisite about the LDLT is donor safety. So we have to understand this operation is not for the donor, it is for the recipient. So donor is by the voluntary choice. He, after understanding everything, then he opts for it. So as a surgeon, what our duty is to make it very safe. What is the level of safety? Ideally, there should be no mortality. There should be minimal or no morbidity. And there should be absolutely good functional recovery. According to the patient's job, if somebody has doing different jobs people do. So these are three ideas which have to be looked at first. And then also important is recipient survival. So any technique of the donor hepatectomy is not only related to what surgery you do for the donor. It has to have the assessment of the outcomes in the recipient. So it should not hamper those or bring it to the level what is in open donor hepatectomy. So donor safety and recipient survival are two primary objectives, as you said in the beginning. But also we have to understand, is donor hepatectomy as same operation as the resection hepatectomy for anything? And as you know, it's not. When I is a resection hepatectomy, it is a cytoreductive surgery. But this donor hepatectomy is two operations. One is a surgically precise hepatectomy, and then added to it is the reconstruction part. So these are actually two parts. You take the liver out and you put in the recipient. So what you take out has to be absolutely surgically with surgical precision, and it's because it has a bearing on the outcome in the recipient. So you cannot equate it to the resection hepatectomy. And we also know, suppose there's a right hepatectomy. It is not the right hepatectomy. There are multiple right hepatectomies for the donor. There's a, you take modified graft, you have standard liver graft, you take partial middle vein, you take subtotal middle hepatic, then there are posterior sector grafts. So it is a complex of operations. It's a number of operations that can be, that are varied according to the taking into the consideration the anatomy, the donor remnant, anatomy, demand, and is it what is the quality of the liver, how much is needed in the recipient. So these all, as Rajesh excellently elaborated, these are like complex jargon, many things which you have to take into consideration, not only pre-operative. When you are operating, starting to operate at multiple stages, you have to have checks and balances where you go. When you start a transaction, what you may sometimes change your level. Where you divide the middle hepatic vein. So these all things come in the donor hepatectomy. They are not same as the resection hepatectomy. That has to be very well understood before we think of applying minimal invasive surgery to the donor donor surgery. So when we think of minimal invasive surgery for donor hepatectomy, what is most important is the donor safety, whether it is related to mortality, morbidity. So there are two things. Why people want minimal invasive surgery? It is good, cosmetically good. It is functional recovery, good recovery. So there is a balance. On one side, morbidity doesn't impact of the outcome of the recipient, and other side have cosmetic effects. So we have to see, does that really, does that really matter to the patient or to the donor? These all considerations have to be discussed with the patient. They have to be fully evaluated. And then most important thing in any technology is the reproducibility. If every donor surgeon, everybody who does a donor is not able to do the way it is done in the high volume, this minimal, wherever like Korea, they do minimal invasive surgery. If we are not able to reproduce it, then there is a problem with the technique only. You cannot, it's a problem with the surgeon. The reproducibility in any surgical technique is a must before we can apply. Ultimately, it is everything has to be applicable to the patient care. So reproducibility is a must for the patient care or donor safety. Then also, it is not necessary that donor hepatectomy is laparoscopically feasible, so we should do it. So there's a big question of feasibility versus applicability. Just because something can be done this way, should that be done that way? So there's a big ethical question in that. And then any technology, suppose you are having an iPad and only some people know to operate it. So is that anything relevant to population? No. So we have to make sure that whatever technique we apply, can we pass on easily to the people? Can they learn it fast? How much time they take? And then is it safe? The most important, is it safe? Are the results same as open? These all things have to be considered when we think of the minimal invasive surgery. Then of course the cost, which is very important in our part of the world. So why do we do minimal invasive surgery? Everybody knows, it is just, replica of what is done in the laparoscopic surgery or robotic surgery in other surgery. Just it's the minimal invasive, faster recovery, small incision. But as Ashwin said in the beginning, if that small incision, when we take the liver, it gets crushed. So what is the use of that long operation? Or any problem happen? Or there is a prolongation of time of taking the graft out from the abdominal cavity. So these all things matter. And then obviously better cosmesis and lower incisions, hernia rates. These are, I think they are minor issues as compared to the donor safety and morbidity. So is laparoscopic donor hepatectomy, I will go first to the laparoscopic donor hepatectomy, is laparoscopic live donor hepatectomy justified ethically? I mean, we already, as is written, we already know that open donor hepatectomy, as you said, it is associated with risk of mortality. And there is a significant morbidity, up to 30% in right lobe, across the globe, across the centers. If it is already there and we apply minimal invasive, does this risk increase? Is the technique justified if it increases these risks? So any new surgical technique must be safer, or at least as safe as standard procedure to be ethically justified. And if we take the consensus of the laparoscopic hepatectomy, even the most recent consensus tells only left lateral hepatectomy is, advised laparoscopically. So although laparoscopic assisted donor hepatectomy have been reported and they are being done, but laparoscopic left lateral hepatectomy, left lobe donation, that is something we have to look in, and that is something I will later on tell why I feel that left lateral donor should be done and why not right lobe should be done, or at least they should be done in a very high volume centers or people who are very proficient in minimal invasive surgery beforehand going to the donor hepatectomy. And if you look at this from David Cohn, I remember I've been there for nearly 15 days watching him doing laparoscopic donor hepatectomy, and I remember, he could suture with 6 of proline easily any hole with laparoscopically. So we have to think, if there is a complication, there is bleeding during the donor hepatectomy, are we able to manage it laparoscopically? That is when you decide that you should apply this to the donor hepatectomy. If you look at there's a 41 right lobe donors, with 10 with the extended right lobe, 3 with the left hepatectomy. The major complication rate is 16.7%. And patients with the big normal anatomy is 9.7, but when there's anatomical variation, it comes to 45%. I talked to him, he said he has many donors who had done RU after that biliary complication. In front of me, he could not do the cholangiogram for 3 hours. He really struggled. People of his proficiency can struggle so much during the laparoscopic surgery. This is the same paper. If you look again, there nearly 50% of the donors with portal vein or bile duct variations have nearly 50% complication rate. Leave aside the normal anatomy. Even in the normal anatomy, you bleeding, portal vein, stenosis, and this is 4 of the donors in this series. They converted, and the 2 reasons were, one, he had that when he applied the stapler to the portal vein and that fired more towards the left, there was stenosis of the left portal vein, so he had to open it. And these don't, then you come to the recipient in this series. You look at the graft failures. There's nearly 10% graft failure rate. So what does that tell? Why is the reason? This all had to be looked in the. If somebody wants to follow the laparoscopic donor hepatectomy and want to do it, they have. These are then this is another center from the Korea, from Su, Professor Su, who published. I will be showing you his recent series in the AJT. If you say earlier series, 26 donors underwent purely laparoscopic right hepatectomy, and in 2 donors the dissection plane at the right deep portion middle vein was not correct. 1 donor experienced portal vein injury during cardiac lobe transaction. 1 developed remnant left duct stenosis. 1 donor experienced remnant portal vein angulation due to the different angle in the stapler which he fired. 1 experienced arterial damage. And from the David Cohn only, if you see that when there is an anatomical variation, if it is type 1 anatomy and everything, they nearly use this laparoscopy, does all this laparoscopically. But when it comes to the type 2, type 3, type 2, very few they take for the laparoscopic donor. So there has to be very selective patients. careful selection, even in the centers who are very proficient in laparoscopic surgery, whether they do donor hepatic, whether they do liver resection, there also it is highly selective. Slight alteration in the anatomy, they will not do laparoscopy. And this again is from the Korea. This was for the, I mean, all the dried lobe. If you see now in the left lateral donor hepatitis, this is by Professor Kim, who heads the department now. I mean, if you see in the left lateral segment, it is nearly the results are similar. So it is safe, feasible, and reproducible procedure, left lateral. Why? It is intuitively, the right lobe is a globular structure. Anybody will say to use multiple sticks to handle it, and if it is little fatty, which our donors are more, I mean, anytime it will go into liver and tear the liver off. Mobilization of the right lobe is difficult. It is intrinsically difficult procedure. But left lateral is a leaf-like. There's no left ducts or is long, left portal vein is long, left artery is relatively easy to dissect. It is laterally placed, and the transaction line is relatively smooth. There is no problem that you have any, at least till the end of the left hepatic vein, where there may be multiple variations of segment 2 and 3 really different ways. Till then you don't have any problem. And then left lateral donation in our countries for kids. And many a times, I think majority of it is the mothers who donate them. So they need to recover very functionally to nurse the children. I think, I mean, this is why I do robotic left lateral donor hepatectomy. That I have seen you use a really advantage. It is a very reproducible procedure. Is the same Professor Su, if you think in the American Journal of Transplantation, 60 pure laparoscopic total donor hepatectomy. There is not a, hybrid procedure. It is laparoscopic. Results are similar, but after how many years of experience, such a long curve. And Professor Su doing how many rest of the people can do across the world like that. And if you see, if you come all these laparoscopic, robotic, they are all Korean centers. And they are very good, all of them who do even robotic surgery, they're very good laparoscopic surgeons. This is the combined series of 5 centers in the laparoscopic, Korea, pure laparoscopic donor hepatectomy, even liver transplantation. And they showed 544 donors. Out of that, right by 481, 25 left hepatectomies, 39 left lateral segmentectomies. And although, even they in the conclusion, although results are comparable to those previously reported open donor hepatectomy, further studies are needed to consider pure laparoscopic donor as a standard of the practice. This is from the people who are the best in the business. Look at Dr. Choi, Professor Kim, Su, David Kuhn. They are all best in this laparoscopy. Even they have this. It has to be careful. It has to be selective, and it has to be safe. And this is another. See, we came in analysis of surgery in March 2017. It is across the globe. There are some centers across USA and also these Korean centers. There are 412 minimal invasive donor hepatitis. But if you look at the data, are nearly the hybrid pure laparoscopic donor hepatectomies were less as compared to the hybrid procedures. And 108 experiences, 120 complications, and nearly 10% severe complications. So we need to look at whether we are ready for that. These are the 10 experienced centers. These results are comparable to, although they are comparable to open donor, but these are the people who are good in laparoscopic surgery. So it is a long curve. Whether we should go for laparoscopy, it has to be very guarded. It has to be a cautionary tale like laparoscopic surgery. It has to be a lot of caution before we go for the laparoscopic donor hepatectomy or advise laparoscopic donor or start doing, or even if we are doing laparoscopy surgery, till we do a lot of hepatobiliary work laparoscopy, then only we should jump to the laparoscopic donor hepatectomy, and that has to be hybrid procedure. Then pure laparoscopy, it is a long learning curve. And obviously, what is the worst part of laparoscopy? It is not easily reproducible. Their experience is not easily reproducible. So how does the robotic come vis-a-vis laparoscopic surgery? I mean, it's like why it is better, because it is like nearly normal. Everything is like open surgery. There's 3D vision. There's 10 times magnification. I mean, there is augmented dexterity. There's endorist movements. There is filtration of the surgeon's movement. Tremors get filtered. All the limitations, the angulation part, when you spiral step, why they have that stenosis? Because you don't have angulated instruments. There is a tremor amplification. There's a fulcrum effect around the port. It is a fulcrum. There's a limitation of the freedom of the movement, and it is tiring. It is a tiring, and unless somebody is doing day in and day out laparoscopic surgery, I think it is little different. I have seen Professor Han, Su. I visited their centers. They are quite good in other hepatobiliary pancreatic surgery laparoscopy. But robot has a little advantage. But obviously, nothing comes up full. And there's some disadvantage. The biggest advantage is limitation of the tools. The main device for the transaction, that harmonic device, it is not endoristed. All the harmonic is not endoristed. Then we don't have design robot. Then it needs a very well-trained surgeon at the patient bedside who is very good in laparoscopy. So it is a double surgeon game. You need one surgeon who is equally proficient at the bed. Patient on the patient, near the patient part. And obviously it is a little high cost, but it is still something which is evolving. Which will see at the end, the laparoscopic surgery is a technique which depends solely on the expertise of the doer. Robotic surgery is one where the learning curve is very short. It is just like the open surgery. Only thing is there is shortage of the instruments. And the robotic is evolving very fast. But it's not that the robot came later. That many people have confused that robot came later. If you say Giuliani in 2003 did laparoscopy first, and in 2012 he reported first robotic assisted right lobe donor hepatectomy, and in 2013 first right lobe laparoscopic hepatectomy was reported there. So it's just that laparoscopy took off earlier because of the availability of the robots. Then people were already proficient with the laparoscopic other procedures, so it took off. But robot is a thing that it is evolving. We had SI systems, they are becoming smaller. There is a miniaturization of the robots. Their dexterity is increasing. Earlier there was a big the issue of if you need to open dedocking will takes little time. That during that time there may be complication and something untoward will happen. But all things are evolving. And then there is this we don't have sensory field. But now this Google and Exclusion are making new robot where there will be navigation-based surgery. So it is all evolving in the process. The first series came from Taiwan by Yaming Wu. Yaming Wu did 13 patients, highly selective. Between May 2013 and August, nearly 2.5, he did 13 patients only. And during that time, I have asked him, during that time, they nearly did 250 living donor liver transplant. So it was very highly selective. And I still carry, I thought I will share that video. He should give me one video, the first initial donor hepatectomy robotic. If you see the cut surface is nearly charred. No donor surgeon will like to see that cut surface. But it evolved slowly, but they're very selective in the donor selection. then this is from, the boss of the robotic surgery, G.I. Choi. I mean, he's very proficient laparoscopist and very good robotics. And he's not actually a donor surgeon or a transplant surgeon. He's like hepatobiliary surgeon, but he does it very nicely. I mean, I got trained with him only. I mean, for quite some time. I mean, he published this series of robotic donor hepatectomy versus conventional donor right hepatectomy versus laparoscopic donor right hepatectomy. If you see that, he said that body image and cosmetic appearance scores were significantly higher in robotic assisted donor hepatectomy. Although robotic donor hepatectomy was associated with a longer operative time. And one thing we changed now, if you have the meta-analysis of the robotic versus laparoscopic liver resections that showed the blood loss was usually higher in robotic liver resection, but he showed a donor where the blood loss was less. So that is one thing we have to look whether body image, cosmetics that takes precedence over the safety and outcomes that has to be seen. But robotic, obviously, I mean, it is nearly replica of what we do in the open. And if you see this new journal, it has given a good, this thing, a laparoscopic robotic open donor hepatectomy, is a scoring of the system. When you have hilar dissection, open is the best. Next, it comes to the robotic donor hepatectomy and laparoscopy scores the least. When you come to the parenchymal transaction, because we don't have QSAR and the harmonic is not endoristed, the robotic is inferior to both of them. But ischemia time, if you see nearly the best score even is in the open donor hepatectomy. Only thing both the things outscore is cosmetic factor. That we need to see. So in the conclusion, I will say donors, I mean, is this the donor safety? We are not sure whether it is safe. It is safe in the hands of the people who are doing laparoscopy regularly, who know about donor hepatectomy, their long learning curve and selected, because most of the series are from the Korea. I mean, we're not sure selected center. Left lateral segment, as I said earlier, it is really advantageous. It is easier, it is replicable, it is safer. There is no problem that you will stenose the left portal vein, there will damage to the right duct. Then it has a good functional outcome. I mean, left lateral giving big incision. I mean, it is advantageous. But I have seen among the donors I have done robotic left lateral donor. It is actually good. One thing in the robotic instrument is initially the movement of the arms is more when you start with. The movement arm, if you see in the laparoscope, the port and this one, the movements are horizontal. But in the robot, the axis is around the anterior abdominal. So there is a churning. So if you take a lot of time, there's like mechanical grinders in the abdominal wall. They have a lot of pain post-operatively, some of the patient initially. So when you get used to it, the movements are less, then it really, you feel that this is something which obviously is the future. Future, we don't know. You see, we may say that robots will evolve over the time, they will become better, but at the same, we may have bioartificial livers. We may not need so many liver transplants. So we don't know really what the future is. But this is evolving. We need to see it. I just, if Ashwin permits me, I just need to show you a small video of robotic left lateral donor. Why I have said there's little advantage and disadvantage. Is that okay, Ashwin?
Sure. Please go ahead.
Yeah. This more video then. Yeah. Okay. This is one of the left lateral donor hepatectomy I did. You see that this is quite easy that you do it is like open. Are you able to see it?
No, we still can't see it. So you might want to stop sharing the screen for the presentation and start sharing it.
Can you see now?
Yeah, it's visible now.
Yeah. If you see, it is like, I mean, left lateral, this is lateral, it is very easy, you hold it. I mean, you will feel it. There are some issues which I wanted to just highlight. I will maybe I will little, sometimes it is like small video. You see, top of the KY, it is like, I mean, then you can just reproduce what you do in the open. So ultimately in the minimal individuals, if you are able to reproduce what is done in the open, then actually it is worth doing it. But at the same time, if you see that retractors that you have to put retractors, they get moving, so if the liver is fast, soft, these instruments, they're very traumatic. The robotic instruments, they are very quite traumatic. But you reproduce what is do you do knot tying, everything is like open. One thing I wanted to show you is how beautifully you can see the quadrate vein and dissect it. And this is a 10 times magnification. You can see that you can acknowledge the amount of movements. I mean, how easy it is to do. I mean, left artery, this left portal vein. I'll just go. They are long stumps. The left portal, this left artery is quite towards the left. You don't need to go all around the porta, damage anything on the right side. Just do little. Just loop. See, but there is limitation of instruments. You see, there are only few instruments available for you to work with. So I'm trying to loop the left portal vein. I mean. It is in Maryland. It is quite traumatic. If you want to push it around, you can easily go into the portal vein. So I try to hook with this loop with the hook, then go below it with this one. This is what we just for traction. I mean, this is Dr. Choi's technique. He does it, and it's very quiet. It makes the procedure very easy. Even when you are doing right hepatectomy, robotic right it makes it easy. See the left lateral, it is no issue. Just like you use these both two instruments, that harmonic and Maryland bipolar, you use in the tandem. One cauterizes also, and you would use them as a chelicalesia also, and you acknowledge the movement, the grades of movement you can go around. It is easily. I just. So you use both these instruments in the tandem, and one thing is, you see, it is a crushing technique. So you have to be little safe. You keep little liver tissue on the left hepatic vein. You have made the window on this, and I'm trying to go beside that. That is what I wanted to acknowledge. There is limitation of this doesn't have the harmony, doesn't have the endoris movements. I think that should be enough. Yeah, thank you very much. I mean, I'm done. Can you hear me?
Yes, and thank you, Goja. It was an excellent talk and an even better video. You gave quite a balanced view of all the three procedures, I must say. To start the panel discussion, if I may request Dr. Srinivas Reddy, who's in the audience, to join us, and Dr. Vinay Kumaran, who's also, is he still here? Sorry. Dr. Vinay Kumaran?
Yeah. Hi.
No,
Vinay is there, but we're glad if Vinay is has his camera on.
You want my camera on? Okay.
and Dr.
Just a
Srinivas
moment.
Reddy he hasn't joined in. Now, I'll go quite sequentially with regards to the questions which I would like to throw to the panel. Rajesh, if you could have your video on as well. Yeah. So I have a few case scenarios which I'll share. I have only about 2 or 3 of those. But the aim is to try and highlight the different factors which need to take in when one goes and choose a donor. I'll just share the slide. Yeah. So if we can see the first scenario, which is a high MELD recipient with ACLF, who obviously needs an urgent transplant. Now, we have one prospective donor who's a 25-year-old son with an okay BMI, but the remnant is only 20%. With, with an okay GRW or acceptable GRW of 0.9. On the other hand, we have another donor as well who's 53 years old and with a BMI of 24. And if we choose the left lobe in him, he would have an expected GRWR for the graft of 1. But his AST, ALD of slightly off. So if I can throw it to the panel, we can start with Goja first, and then maybe Dr. Vinay, and then Rajesh can come in last. And whom would you choose, or would you actually turn down both? Well, what would you like to do here?
I mean, I just missed your this 25-year donor and this 50-year-old brother. I will obviously choose 25-year-old son to donate. You see, I will do because a young guy and the good quality liver, and although 29 5 you will do modified graft, and I think I will go with that. I mean, that is what I'm not happy with the AST, LT high. Would you? I mean, I'll do biopsy with them, and we'll see. We'll do all investigation before that. But doing left lobe with high AST, LT, we have seen that. You see, to be honest with you, left lobe livers, whenever we put, the results are not that we have not seen those. And if the already enzymes are high, he's like 53-year-old. I'm not sure. I will go with the first donor. I mean, that is what.
So, if I can summarize the reasons for your rejection, it's the age and then the borderline AST, isn't it?
Yeah.
Rather than anything else.
Yeah.
What about you, Dr. Vinay? Would you go for the son?
So I would turn down the son altogether, because I think whatever criteria we need to put for donor safety should be absolute. So even if it's 29.9, I think I would turn the son down. That's not a modifiable factor. Now the brother, the enzymes might be transiently high. They might come down. So I would check autoimmune markers. I would repeat the enzymes, see if they come down, do a liver biopsy. And if those things are okay, if the enzymes come down, I have no problem using him as a donor.
Right.
Donor safety is always primary. So it always takes precedence over recipient issues.
Yeah. And it sounds extremely reasonable. Rajesh, it is one of your patients. So what did you do in the end?
Actually, to discuss the 53-year-old donor, obviously the risk for the donor is less in them, except for the transaminases. If the transaminases settle, donor issue is not there. But obviously, for a high ACL 53-year-old donor, recipient can have problems. But 25-year-old donor with a remnant of 29.5, I would like to actually understand, I will revisit on this 29.5 and then actually go into the radiology part of it and understand whether there are times where it is 29.5 and then when you go in, they have a very good segment 4 portal pedicle. What we calculate is based on the middle hepatic vein. But actually when you go in and then look into the portal system of the segment 4, they actually cross very well the middle hepatic vein, and then actually intraoperatively you might have a good demarcation towards the right. We actually went ahead with this 25-year-old donor. In fact, because of this same reason that he had a very good segment 4 portal pedicle. We didn't have a software based which can predict based on the portal structures, portal supply. So for us, it is like we went ahead with the 25-year-old.
So for this 53-year-old prospective donor, did we actually see why the AST-ALT was higher first? I mean, did we look at him seriously, or we said no to him at the outset?
At the outset, there are a strong rule. If there is more than one risk factor, and there is an alternate donor, we actually we especially with old age, that we consider donor age as one of the most important independent factor, not only for the recipient as well as but for the donor as well. So here 53-year-old as well as transaminitis, it's a big thing. In fact, the Kyoto donor death that happened, in fact, if you permit me, I can tell the scenario where actually they took the patient. It is a 50-year-old mother who wanted to donate, and then they went ahead. The initial assessment was 37% remnant, and then the plan was to leave the middle hepatic vein. But intraoperatively, they felt that the remnant is okay, and then they went ahead, and then they did the MHV. Intraoperatively, there was a change in the decision making. They went ahead and then took the MHV along with the graft. But later on, the donor was struggling with liver function test. The donor actually had a resurgery, and 9 months down the line, actually the donor died purely because of liver dysfunction. And when they reviewed the biopsy, it was NASH. So many lessons was learned in the story. One is last minute change in decision. When they actually calculated the liver volume with the middle hepatic vein, it was 28%. So from 37% to the right of middle hepatic vein, it changed to 28. There are a lot of these factors, and a 50-year-old donor. Small things where there is more than one risk factor, it can completely change the scenario. So I would say that there may be more problems or risk factors in this 53-year-old. There are less chances in a 25-year-old. I would this is what I would go with 25-year-old if, as I said, it's a good segment 4 portal tract, and then we feel that the demarcation is more going to be observed. Otherwise, I will deny both.
Ashwin, can I add something?
Okay.
Can I say something?
Yes, please.
Yeah, I agree with Rajesh. You know what? Most of the times we see these younger, they have a good segment 4 vein, and there's some volumetric. But when I said that we don't shift the risk to the donor. But we will reassess it. We will get multiple radiologists to reassess the volumetry exact. We'll see the demarcation. Then, you know, sometimes what we do is in that when you go to the top towards the segment 8, we usually switch the transaction line little towards that, make it more non-anatomical to put it more, get a liver volume more. And we usually take modified graft and we will extend. We may not reconstruct. There are multiple papers, even if you don't reconstruct segment 8 vein, it doesn't affect. But we will always make sure, I always make sure that segment 5 is drained in the recipient. For segment 8, you can make little non-anatomical, put it to the other remnant side. 25-year-old with good BMI with 29.5. I mean, it is roughly around 30%. I think that that is why I said I will go with it. I mean, I don't know where Rajesh selected that only.
If I may add, actually, Professor Rela used to say that to recalculate the volumes, 1 centimeter to the right of middle hepatic vein, for the same reason probably. and then reassess the whole volume. And then if it is coming up to 35, and as I said, if the segment 4 pedicles are good, actually, especially in young donors, as in 25-year-old. Obviously, independent scenarios, we have to take a call based on the scenarios as well.
So the if I can take a learning point from this, it's that age is a very important factor in regeneration, and it needs to be due credit. And then if you have more than one morbidity, obviously you would look for another donor. And the other thing is, if you can't change the donor, change the radiologist. You might get better volume
No,
assessment.
I think that's a bad idea. We should not change the numbers we don't like. So it's always possible to change the plane of transaction and get a number that you like. But I think the first percentage that you get, you should stick to it. I think it's a bad idea to change the plane of transaction just so that you can get a better number. That's a dangerous way to go, and there's no telling where to stop.
Yeah.
You can get 25% to 30% if you want to.
Sure. Yeah. If we can go on to the second scenario, which is slightly less controversial, I just wanted to highlight this case for a very particular point. So, and we have this 45-year-old lady who's from South India, shall we say, and the recipient is HCC within Milan. And this donor has a BMI of 30 with LAI of +1, FLR of 33%, expected GRW of 1.1. Triglyceride is slightly borderline. 150 is the usual cutoff, 190 here, and ALT is also slightly off. How would you go about this, Goja? How would you like to take this further?
You see, obviously, as Rajesh told, the more than +5 is what is needed. So her triglycerides are also high, and I will just look. We put on that rigorous exercise regime for some time, which the endocrinologist maybe. I mean, we always go if there's a double, like triglycerides are also high, BMI is, LAI is low. We'll do biopsy also, especially with remnant. I'll definitely biopsy it. And then we take the call later when everything is better, if it gets. But obviously, LAI +1 will not do. I mean, that's not LAI. This is a fixed LAI more than +5, and we will put on that regime that to make it to improve the LAI and to repeat the volumetry after that. That is most important, because liver size may decrease, maybe the fatty high, volumetry will come down. And a biopsy the remnant is a must.
Dr. Vinay, and would you say yes to this donor? Would you reject outright?
No, we certainly wouldn't reject outright. And we have time here. And this is a South Indian lady. You keep her from eating rice for 1 month and everything will come back to normal.
Absolutely. Yeah. Fair enough. Rajesh?
As I said, the situation gives enough time. For example, this patient within Milan criteria, HCC within Milan criteria, there is enough time to optimize the donor. Obviously, in this situation, taking no other donor available, we can give time and then optimize, and then we do repeat biopsies. Transaminated, to be frank, my worry is more related to the transaminators. So we need to make sure that there is no NASH component with 33% remnant. That will actually influence the donation for the donation. So repeat biopsy should be good. If it is worrying, then obviously they need to. I don't think this donor should go ahead if the repeat biopsy goes, even after giving enough time.
Sure. It's what I wanted to highlight. So as we are waiting for this donor to lose weight and improve on the LAI, we should also think about having this recipient on the DDLT wait list as well. So that, we do have time. So, in our scenario, especially in South India, we have that option and we should think about that. Just because it's an LDLT talk, we shouldn't only think about LDLT. We should have DDLT in the background as well. Third scenario is something slightly more complex. It's an 8-year-old acute liver failure, Wilson, so obviously needs transplant. And father has a low serum ceruloplasmin, but mother who's also willing to donate but is ABO incompatible. Goja, how would you like to go about that?
Is it I mean, we can do ABI. What is there's nothing. Oh, if you go into for the ABI, Papa nowadays we doing acute also ABI. Because we need to evaluate the father fully before we can think of. I think mother ABI incompatible. I think they reported some of the cases doing for the acute cases also, and there's a good results. And can consider in this acute emergency.
Conventionally, but ABO incompatible for acute liver disease is known to
It's
have.
not, but now some people have even Amrita they reported they did some ABI incompatible with good results. So we have to look at it as a progressive thing. We can't stick to something which was happening and stick to it. In the acute emergency, we have to think about it.
Sure. Okay, so you would go with the ABO incompatible for the
Acute
mother.
emergency, we will evaluate father fully. Before we think of.
Okay, Dr. Vinay, what about you? Whom would you
So
choose?
there are a couple of things to look at. So both the parents are going to be heterozygous, and if the father's 24-hour urine copper is normal, there's no problem him donating. You might want to do a liver biopsy to confirm that the liver is normal, but he should most likely be able to donate. But the other issue is that if you check the antibody titer against the mother's ABO blood group, and you have a low titer, you have a titer of less than 1 in 32, then the mother is just as good a donor. So both options are on the table, and it depends on the 24-hour copper in the urine and on the antibody titer, which way you go.
And it's an excellent point you raised about the 1:32 titer, especially if it's an A2 blood group of the mother, then it
If it's
makes
A2, then you don't even need to look at the titer. You can just go ahead.
correct. Dr. Rajesh, how would
Same here as Dr. Vinay said. The only thing is ABO incompatible in acute scenario situations. It also depends on the time that you get before the recipient, like whether there's time. But I would go with the father if say like 24 hours urine copper is okay, and the biopsy is okay. Then I will go with father.
Sure. And again, another question in acute liver failure is the donor evaluation any different? Because obviously you would have only about 24 hours, maybe maximum, maybe 48 hours, not more than that. So is there an alteration in the donor evaluation protocol itself for an acute liver failure patient? Goja,
No, it has to be same, but it is little faster. And as they said, the father, I mean, this we have to do 24-hour urine to liver biopsy. Both are equally good donors. I mean, according to antibody titer. But it is same protocol which is followed, and it is little expedited and fast. Otherwise, we do same CT. We do same procedure what we do. Maybe we do CT very early to see the LAI, everything, volumes are okay before we do. Otherwise, same protocol. We but little we do it faster. There is nothing shortcut done for the donor because donor safety is important.
yeah, that's right. Do you agree with that? For acute liver failure, would you have the same donor protocol evaluation, or would you modify things because of time
You do the
constraints?
tests simultaneously rather than sequentially, but you do the same tests.
Yeah, absolutely. Rajesh,
Yeah, same here, but have a very low threshold for liver biopsy in any difficult any scenarios where there is a doubt.
I have a fourth scenario, which I don't have a slide for. It will be the last one, and then we can go on to further questions. The scenarios instead of having acute liver failure and Wilson's, if it is autoimmune hepatitis, and then you have a donor who's like, say, a first degree relative, say the brother, and he has ANA positive. He's also antibody positive but asymptomatic. Would you choose him as a donor? What would be your selection criteria? So you have a recipient who is autoimmune hepatitis, CLD, who needs a transplant, and you have the prospective donor who's the brother, who has ANA positive. How do you go about that? Goja, what would
Biopsy, with biopsy, I mean, biopsy, you can do it further, and if it is okay, we can go ahead.
Right, right. Okay. Dr. Vinay?
Yeah, I mean, the donor should be aware that they are at risk in the future of getting autoimmune disease of the liver, but that doesn't change their risk of donating at this point. So that would not rule them out as a donor.
Would you do an extended autoimmune panel? You maybe say include things like SLE or something else in your evaluation, or would it be just the routine autoimmune test?
The routine, if the liver numbers are normal, then we don't gain anything by trying to figure out which markers are positive.
Rajesh?
Yeah, same here. They can have a liver biopsy, but they need to understand in future that they can have like problems, but definitely not going to affect the current scenario, the regeneration and stuff. With the liver biopsy is okay.
And I would document this also in the consent that they are aware that they are at higher risk of developing autoimmune disease in the future, and that it is not because of the act of donating that is going to happen if it happens. So we would typically include a sentence in the consent saying that, so that you don't get into trouble 5 years later if they get autoimmune hepatitis.
Again, with regards to the pre-donation workup, we normally use a CT in our center. How effective or how much better do you think are these softwares, like you have MBBS and all of that? Dr. Vinay, Dr. Sanjay, would you like to take it? Dr. Vinay, would you like to tell us your perspective first?
So when I was in Mumbai, we were using something called Miriam, which is easy to use, and it's nice. It gives you a good 3D image. It lets you calculate congestion volumes of the veins you're planning to ligate. So it does help you in your surgical decision making. Over here in Richmond, we have something called Singo Via, which also has similar functionality. So you can manage without them, but they're good to have. So I think if you don't have them, it's not that you have to have them, but if you have them, you use them.
Dr. Goja, have you any experience with that?
I think, as I agree, I mean, they are not must, but they give some added value. I mean, you can have that estimate of congestion, drainage, but obviously we got some people with maybe some time back with this one, but they are not must. I mean, they are obviously good. I mean, it gives a good way when you look at the pictures. There's a good way you look at them, and then you have, but they are not must. And I think ultimately this all is the experience based and a lot of. I mean, pre-op, you have to do a lot of thinking. And one thing I have seen over the time is recon images should not be looked at very seriously. We should do action imaging very detailed and look at those, especially veins and all that. Then we put a recon image, and then there's some error sometimes there. That is something which I have seen over the time. Rest, I mean, these are added. They are there, good, but they are not there. They are not must.
Sure. In the operative steps of donor hepatectomy, we now have intraoperative cholangiogram and we have ICG as well. So now we have three opinions: either do it selectively and not do it often, or you do it routinely, or which one would you choose? Dr. Sanjay, Dr. Vinay, and we have also in the panel. If he can switch on his video, I didn't realize he had joined us.
You see, when I do this robotic, that is in the ICG is there inbuilt, so it is very easy to do, and you get a good idea of that. But besides that, intraop cholangiogram, as you said, I mean, from your center already they get cholangitis patient get cholangitis. If it is, you are very clear, you are seeing on the pre-op MRCP the second level ducts. It is a type A anatomy, and you are very clear, then you can get away with it. If you have some doubt during intra, you think that the anatomy is not that, you are not sure about the pre-op MRCP, is not good quality, you are not able to, or the anatomy is, it is not type A or something conventional anatomy, there are anatomical variation in the biliary system also, then we can do it. But at the time of transaction, I don't do this one demarcation. I don't do that type of cholangiogram. and I tried to restrict doing intraoperative cholangiogram as much possible as is because of the risk of this one. And one thing Rajesh showed that putting the down intra clamp and all that, I mean, that may help. And but I try nowadays we try to restrict, but it's not that we got everything, but we do it very selectively. But it is in present practice more than not doing.
Right.
Understand?
Any experience with the ICG camera in the open surgery and as compared?
No, I have never done ICG in this year because the robotic system has inbuilt ICG, and then it gives a good hang of it. So especially I use it in hepatectomy, robotic hepatectomies, and you have good at it. That is why, because it is inbuilt in the system. That is why it makes it convenient to do. Okay.
Dr. Vinay, what is your usual protocol? Do you do a IOC in all cases? Would you
Yeah, I
like?
do an intraop cholangiogram in the beginning to confirm the anatomy, and at the end to confirm that the stump is adequate and there's no narrowing. I don't normally do it just before transection unless there's some doubt about where to cut it. Usually there isn't, and I don't have any experience with ICG.
Sure. Rajesh?
Yeah, can I add? So this is what was like regarding the first point, the number of times a cholangiogram is done. It's 2 times, isn't it? Once you want a baseline and whether you have the completion thing.
No,
So
sometimes they do it thrice as well.
yeah, twice. No, what I'm talking about is most of the centers are going for twice. So if you have a very good preoperative RCP, the need for the first cholangiogram is off. Okay. The need for the last cholangiogram, if you because the opening is there in front of you and you can probe it, and you can go through the segment 2 and 3 and 4. Actually, personally, that's why this is the reason why actually we moved ahead. In fact, even before when we are doing cholangiogram, it is only twice, not thrice. And now from 2014, it's almost like very like only some 5-6 cases we have done the cholangiogram. I'm not saying that this, but people need to think and once this introduction of ICG, especially in open surgery, I have experience. We have used in over 10 patients of them. It's only a demo mission that we had from Stryker. So what we felt is it is real time. ICG, the advantage is real time. Just that you need to take the tissues off because the ICG the dye, the time of the dye giving the dye should be good, that so that the bile duct is visualized well rather than the liver. Third is you need to dissect out because 5 to 8 mm is the penetration distance. So if you have a lot of tissues over that, you may not be able to. One important point is if there is 2 ducts and you have cut the first duct, you have to rely on probing to get you to without a cholangiogram. You have to rely on probing to cut the right posterior duct because ICG comes off. So there are situations where they actually put a clip and then they cut it and then they go to the other duct and then do that. I personally, to my this thing, obviously minimally invasive thing coming up, ICG will definitely come in more way, and cholangiogram will slowly will be more and more selective when actually things are not clear, when you want to make sure. And their role will be less and less, and ICG's role will be more and more. All this thing is based on a very good property MRCP, I would say. If that technology moves up, the rest of the role of ICG will definitely come down.
Sure. Of course, ICG also helps the young surgeons to learn
Exactly.
the bile duct division safer, isn't it?
It takes the stress out of you.
Right, sure. And is Dr. Reddy there? I have a very specific question for him. Dr. Reddy? Yeah. Yeah. As the surgeon who has done over 1,000 bile duct anastomosis or somewhere near there, and with Rajesh doing selective IOCs, would you rather have him do intraoperative cholangiograms in all cases so that your duct anastomosis is easier as a recipient of a surgeon, or would you rather be happy that he does it selectively?
I think initially we all felt that when we stopped doing intraoperative cholangiograms, there was an increase in the number of ducts in the graft. I think now it's not that much of an issue anymore because I think it's all part of the learning process and experience. So the donor surgeons now, I mean, Rajesh and before him, Venu, they did get good at guessing where to cut the bile duct.
Guessing.
And I think it's, yeah, I mean, to an extent, it is a guess, isn't it? You don't actually see where the bifurcation is. But I think as you get more and more experience, I don't think the additional benefit of an IOC is as much as it is when you're at the very beginning of your training curve. In terms of the implanting surgeon itself, I think it doesn't really matter if there's an extra duct. I think we've got used to managing them. So I'm sure Ashwin, you know that. So
actually, as a donor surgeon, you should develop a hatred for the recipient surgeons. Actually, your primary aim has to be to preserve the conflicts. So you should always have a hatred towards them, and then make sure the donor goes well.
I'll put that. Dr. Vinay,
Lighter note.
So, do you have a separate donor surgeon and a separate recipient surgeon, or is your team sort of mixed and everybody does it?
In Mumbai, there were 3 of us, and we used to rotate each part. So you divide the operation into 3 parts: donor hepatectomy, recipient hepatectomy, and implantation. We used to take turns doing every component. Here, of course, I do the donor and then I go over to the recipient side and help in the implantation, and I generally do the bile duct myself. It will take some time for everyone to get trained up over here.
So you can't blame somebody else for
I can't blame somebody else, but I still want to be safe with the donor. I will deal with whatever I get in the graft later on, but the donor has to be safe with a good stump that can be closed securely.
It's a fair point. Now, if I may ask, do you have an objective point where you make that first incision? I think the most crucial or the most stressful part of a donor operation is that first nick on that bile duct which you make. We have spoken about this, Rajesh and myself, quite a bit actually. So do you have an objective point or a marker like a vein or I don't know what, where you make that first nick on that bile duct? Dr. Vinay, then Dr. Goja.
No, nothing objective.
So as Dr. Reddy said, it's an educated guess which is sort of going.
Yeah, I tend to be very safe for the donor, so I don't mind leaving a long stump there and deal with whatever I get on the graft.
Sure. Dr. Goja, do you have anything?
Yeah, I agree. It's like a gas, more like gas. You get used to cutting. I mean, you have to get used to that angle, that duct end angle. You just make it. I try to make straighten the common bile duct. Try to. I mean, the falls, the right lobe falls down, and you get that knack where to cut. And it's like, I said, educated guess.
I think the traction on the common bile duct, the assistant pulling on the sling on the common bile duct is the thing which really guides where you have to cut.
And how often do you use what Rajesh showed in the donor operation, checking the portal pressure before clamping, after clamping, like a trial test? Dr. Vinay, Dr. Sanjay, then I'll go back to the question. Do you check portal pressures at all?
You don't expect donors to have portal hypertension, so no.
And
we've never run into a problem like that, so it doesn't seem to be a problem which needs a solution.
Sure. Dr. Goja?
No, never.
Rajesh, we did have one, and it's a question which Dr. Vinay asked in the chat window as well. If you would like to sort of tell us more, and then I have a follow-up question for Dr. Reddy about that.
Basically, it's a protocol. It has been in protocol to measure the portal pressure. That is one reason that we are routinely doing it. More than that, what we have found over the years is whether the difference in the clamp pressure, whether like the influence on the central venous pressure. There are times where we have measured the pressure and it is almost like 13, 14. And then we started understanding the influence of this portal pressure by many things, like even, for example, a bolus of fluid. In fact, there was one donor who received in the staffs gave actually a fluid overnight, and then when we opened, actually the liver was full. And when we measured the donor was 25-year-old, and we measured the portal pressure, it was 13. I was stunned. But when actually we analyzed the scenario, it was just well hydrated and probably given in the morning actually. And then we waited for some time, the pressure came down. So this is the influence of the CEP. So, and at the end of the surgery also, we are happy with having a pressure less than 12 at the end of the surgery. If, for example, there is one scenario where the portal pressure at the end helped is two portal vein scenarios, like a patient with two portal veins. When you have a two portal vein, it is when you apply the clamp on these two portal veins and take the graft out, there is always a chance there can be a kink between these two portal veins. And that kink will not be obviously, the portal pressure below and above can show up the difference across it may be obvious, it may not be obvious, but there is a situation where actually we found that the pressure below is high. So where we have to we have to close it longitudinally, transversely instead of longitudinally, the anterior one, and one where posterior was revised. So these are because we had it as a routine, there are situations, even though it is rare, considering the donor situation, I still feel there is an advantage of doing the portal pressure, and it is not going to harm anyway to the donor. At the end, you have to sleep well at the end of the surgery.
Sure. Dr. Reddy, have you noted any correlation between the pre-clamp portal pressure in the donor and the outcomes in the recipient? I mean, say if you've had a pre-clamp pressure which is high, say 9, then
no, I don't think so. No, I don't think that makes any difference to the recipient outcomes.
Sure.
There's one, Ashwin, I think there's one thing I wanted to say. The second scenario, I think everybody is talking about, the South Indian lady,
yes,
45-year-old South Indian lady. Everybody is talking about biopsying, getting her to lose weight, biopsying again. Yeah. Personally, I don't think a biopsy is actually required in any of these time points. We see a lot of donors like this. Most of them, you tell them to lose weight, they lose 5 kilograms. Your LAI goes up to, more than +5, your enzymes settle down, and, the liver looks healthy. So I would only biopsy her if even after she loses weight, she's still having transaminitis and you're worried about underlying MASH. If she loses weight and the transaminitis come down to normal and the LAI improves, I don't think there's any need to biopsy. That's my opinion.
Yes.
Yeah, I think it's a fair point, Dr. Reddy. I have another question for Dr. Reddy and Dr. Goja and Dr. Vinay Kumar. Is that as a recipient surgeon, would you like your donor surgeon to do open, robotic, or lap? I mean, with regards to the stumps of the cuff or the quality of the liver which comes, what as a recipient surgeon would you like your donor surgeon to do?
Adult versus pediatric.
And apart from the fact that, of course, you have obvious advantages to each of the procedures. Dr. Reddy?
Sure. Okay. I mean, I think, it doesn't really matter as long as the graft that comes out is good. It's well perfused, and I mean, length of vessels is not really a problem. Actually, you can do back table work, and we can manage with short vessels. It's what would worry me is if the liver has been handled too much during mobilization or during transection. So I think once you reach the learning curve in robotic or laparoscopic or even open for that matter, I think that's the key. The liver needs to be handled well, carefully during the hepatitis procedure, so that it functions well post-op. I don't think length of vessels is a major issue for us actually.
No, no, it's quite often to see a much smaller cuff with a robotic uh, donor hepatectomy because you use a stapler on, at the end, isn't it? So,
Yeah.
I was wondering maybe that might compromise the.
Yeah. I mean, we can do, if it's really a concern, we can do a backtable extension of it. But there's the handling of the liver, the injury to the liver is something that you can't deal with. So that's the main issue.
That's a fair point. Dr. Vinay, what is your take on that? What,
I actually posted a link on the chat. So the Samsung Medical Center group looked at recipient outcomes when the donors were done with minimal access, and they found the mortality was 1.5 times higher, and the incidence of grade 3 and grade 4 complications in the recipient was significantly higher when they had minimal access donor hepatectomies. So I think it's partly a matter of ischemia time, partly a matter of compromised biliary stumps. So something seems to make these grafts inferior to those procured open. And this is the group David Kwon and Kim Jong-man. They're very experienced minimal access surgeons. But when they looked at recipient outcomes, they found they were significantly worse.
so you would like your donors to be done open then? I'm assuming.
Yeah, I mean, we are thinking of starting minimal access donors. We have very experienced robotic surgeons here who do a lot of robotic HPB surgery. They do robotic kidney recipients, implantations, and so on. So we're thinking of starting it, but I'd prefer to start it with the pediatric cases. Left lateral segments, there's no controversy. Right lobes, I think, is not yet clear.
Sure. And Goja, and what is your take? If you had to do a hepatectomy as a recipient surgeon, what would you like?
The best option, as I showed in the presentation, is obviously always open. You have everything perfect. Okay. Laparoscopy, is like it has to be done by somebody who is very well proficient with laparoscopic skill. Because this handling, it is right lobe handling is you see, if you see that Professor Su doing laparoscopic right hepatectomy, I saw Han doing it. You will see it is like they do like open. It is something very center specific, and you feel that that the door it is like normal. Doing. But what Vinay said, I also, but it's the initial series from the Samsung. But after that, now their recipient outcome, there was like 10% graft failure rate during those times. But now it is a, they have evolved, it has evolved over the time. But obviously the robotic has a future in the sense that it replicates what is done in the open. Ultimately, we want donor to be done the way it is done in the open. And robotic has always that scope. That is why doing left lateral is like doing open, and doing in a better way, it is 10 times magnification. I show you that the coordinate waves look like big. They don't look so good in the open as they do in the robot. So that is the advantage with that. But robotic doing right lobe, because if you do hepatectomy for a cancer, even if they are very traumatic instruments, and they will easily go inside the liver. If they do in the right way, it doesn't matter. But if you are mobilizing right lobe donor and when the angulate, that angle goes into the liver, then there's a problem. So obviously it is a long learning curve, and applying this to the right lobe donor hepatectomy is something very center specific. Some people who all these studies are from Korea only. That one thing needs to be seen. Except for Yaming Wu from Taiwan who did robotic. Remember, their center, it is a long learning curve, and it has to be very safe. Obviously, open is best. Below open is like robotic, which is replicable, and laparoscopy comes. Just because most of the surgeons, most of the liver transplant surgeons, all the laparoscopic donor hepatectomies who do laparoscopically are not actually transplant surgeons. They are inducted into the system who can do donor hepatectomies. They don't do besides donor anything. So that has to be seen, and also I think robot is better, and it is evolving. It has many things will come over it. It is getting smaller. The instruments, and it has a future, but laparoscopy is a little difficult. It is difficult to replicate. It is difficult to execute, it is dialing, it is long procedure, handling. I mean, globular structure, soft with 2-3 needle type, I mean, sticks, manipulating them, it is intuitively wrong, little something wrong with that.
Sure. And you do post quite a sobering picture of graft donor hepatitis. Are there any questions from the audience? Once again, we've been...
Ashwin also.
Okay. Yeah, so if we have no more questions...
Any Shruti have any comment? Vimal? Anybody? Any query or comments? Yeah, there are none. Back to you, Ashwin.
Yeah, so thank you very much.
Dr. Ashwin?
Yes.
Yeah, I have a question. I mean, the most tricky thing which I find, deciding about a donor when you review his CT, right hepatic vein, right portal vein, artery, you have a very clear idea, and you also get a very clear idea of the bile ducts. But it is the middle hepatic vein that is more of an enigma in planning regarding whether to take it or not. Because if you, most of the times, I find the most difficult part.
We just lost you there, Dr. Khan.
No, he's there, but I think panelists can respond to it.
Yeah, sure. Dr. Goja, now you want to take that? I think what he's asking is, how do you choose the exact plane of transection or the line of transection before you start with regards to the middle hepatic vein?
Normally we...
how do you take a call if you're to the left of it or to the right of it?
You see, normally when I say don't keep, I mean, we do the clamia right hepatic right or demarcate the transaction line. Then we go in the transaction line. I mean, that transaction line, you should not, if you have seen the anatomy pre-operatively, you should not keep searching for the middle hepatic vein. When you go straight, you will hit it, because there will be like 4B5, you will hit it automatically. Don't keep, the moment you stay, you will start tracing pedicle, some of the pedicle, and then there will be ischemic zone. You go straight in it, in plane, you will hit the middle hepatic vein. When you hit the 4B5 junction, then you take a call what type of graft you are taking, depending on the remnant, depending on the quality, depending on the GRW, depending on the age of the patient, the multifactorial. Then you decide how much you take, depending on the venous drainage of the segment 4, multiple factors we have to take into account. Then you decide which type of graft you take. But nowadays, more and more, we try to avoid taking subtotal MHV as far as possible, because when you make new MHV, it works as well, and then there's a survey. That is quite safe. I think that is what majority of the grafts now are either modified right lobe graft, or I take only partial MHV, taking subtotal MHV. But at the end, it is it all depends on multi-factor. But searching for MHV, I don't think when you start searching for MHV. Otherwise, the transaction line will be like all ups and downs. It have to be smooth. That is what.
Dr. Vinay, what's your center policy with regards to the middle vein, and how do you find it?
So finding it is never a problem, because you will find either a segment 4 or a segment 5 which will lead you to the middle hepatic vein. So it's never a problem to find it. Whether you take it or not, we tend to err towards including it in the graft, but you have to take into account factors like what's your remnant volume. So if your remnant is more than 35%, then you can always include it in the graft. Between 30 to 35, then it also depends on how much your graft recipient weight ratio is and which vessels are joining the left vein, which are joining the middle vein, and you decide based on anatomical considerations. But the data from Toronto and Hong Kong says that even if you have a policy of always taking the middle hepatic vein with the right lobe graft, it does no harm to the donor. What you cannot do is always leave it behind, because that will do harm to the recipient. But generally, in about 70% of cases, we would include most of the middle hepatic vein with the right lobe graft. In about 20% of cases, some of it with the graft, and in about 10% of cases, it would all stay behind in the recipient, in the donor.
Right. Rajesh, would you like to add?
Middle hepatic vein, as said. One point which I was interesting noted is when you have a smaller donor or a population, like many of the studies from the Korea and Hong Kong, where predominantly smaller donors compared to North India, probably the Middle East. What we have found is the distribution of the volume, liver volume, is more to the right compared to the left. And in those scenarios, obviously taking a middle vein may not be the same scenario as when you take a middle vein in a smaller individual. So I would say that the liver volume of the right lobe liver volume also matters when you take the middle vein along with the graft, especially when it is like, let's say it's more than 800, 850 grams of right lobe volume in the like maybe more than 900. Then actually you have to think twice before taking the middle vein. I understand that there are calculations you do pre-op, but this is one thing which I find that I think twice or thrice before taking a middle vein in these scenarios.
Sure, thank you. Any other questions from the audience? If not, we'll. Yeah?
Yes. Can you hear me?
Yes.
Yes. Similarly, in continuity with this, has any of the donor surgeons any experience with having a congested segment 4B after they have taken the middle hepatic vein?
Dr.
Did you
Vin?
find it?
Sure.
Yeah.
No, that's never been a problem.
Would you like to take that? Yeah.
Are you asking me?
Yes, yes. Sorry.
Yeah, that's never been a problem. I've never encountered that problem.
Okay. Goja, after you take the subtotal MHV, have you found the 4B to be?
No, because it is all pre-operated, calculated. There's a lot of the fiscal vein, there are multiple veins now.
Absolutely. Rajesh?
But you have to be doubly, triply sure before taking middle hepatic.
In fact, actually, when we take middle hepatic vein, and then even though there is no good visual vein, even there are times like when we start to see the congestion, but even during when you go to the like last part of the transaction itself, actually you see that the congestion and all has gone off. It is the liver has got the pressure inside the congested part has like drained via the other probably a collateral development. So yes, like I have like few times where I started to see, but it immediately disappears. Maybe that's what I feel. But
the Hong Kong group actually did Doppler studies on the remnant. So they always take the middle vein with the graft. They did Dopplers of the segment 4, and they found that in about 30% of cases, what you see is a reverse flow in the portal vein branch to segment 4. So the blood flow is going in through the artery and going out through the portal vein. But it doesn't seem to do any harm. When you look at regeneration of these remnants, you see more growth of segment 2 and 3 and less growth of segment 4 when the middle vein is gone. But in practical terms, in terms of morbidity and mortality, it doesn't seem to make any difference.
Ashwin, can I ask a question to Dr. Vinay Kumaran? Dr. Vinay, you're saying that you take the middle hepatic vein in what 80 to 90% of donors?
About 70%.
70%, and your cutoff remnant is 30%, yeah?
Yes.
So, and you use where do you draw the line? Is it on the left of the MHV or the right of the MHV?
So we follow the ischemic plane, which by and large usually leads you to the right of the MHV. and then we core out the MHV. So we don't shift the plane of transaction. We would core out the MHV from the left rather than shift the transaction plane.
No, when you do your preoperative imaging volumetry,
right of MHV.
Where do you draw the line?
Right of MHV.
So you draw the line to the right of MHV, but you take the MHV with the graft.
Right, but the transaction plane, if you follow the ischemic plane, it usually does lead to the right of the MHV. So we found that correlates better with the graft weight than if you draw it through the MHV or if you draw it to the left of the MHV. So we actually looked at that. So we used 3 different transaction planes, right of MHV, middle of MHV, left of MHV. And the right of MHV plane seems to give you the best estimates of graft weight.
Okay, thank you.
Any other questions from the audience or the panelists would like to make a...
Can I ask one question to Dr. Goja?
Yes, please.
So, if let's say one of your relative has to undergo a recipient of a high male recipient, and one of your relative has to, the donor has to undergo a right lobe donation, and they were asking for a robotic. At this point of time, what do you suggest?
I will not suggest. That's what I am very clear about it. I will not very clear about it. Not that I do robotic hepatectomies. I mean, a lot of, but I have not done robotic donor hepatectomies because
let's say you have the complete expertise now. Like you have almost like 150, 200.
No. I will not put it unless the instrument, the hand. See, I have seen. I mean, it needs to be seen. Those, if you say Maryland in the robot. Anytime you hold bowel cirrhosis with that Maryland, it will tear off the cirrhosis in a second.
I agree.
They are so traumatic. Their grip is not good. They are not gripping, but they are very traumatic. When it flexes, you put on the liver. I am sure people will not report it. There is not a single surgeon where it has not gone inside the liver. It will go invariably into the liver. I mean, I have seen Dr. Choi. I visited this center for quite a long time, and he is most meticulous in robotic surgery. I have seen him. I mean, and for our society, we have. I mean, you have seen how many people have fatty livers. I mean, it is not. I will not advise. Liver side robotic minimal access. I will not advise minimal access right lobe donor hepatitis.
I think it's an extremely important point which Goja has raised. You don't have haptic feedback in a robot as compared to, say, in a lap instrument where you can sort of develop it with time, but you wouldn't have that in a robot. It's the grip which the robot holds. So that's quite important to understand. Any other questions? Anything else you would like to add, Dr. Reddy? Any comments?
No, that's fine. I think the only thing I would say is obviously minimal access and robotic HVP surgery is coming in a big way. I think donor hepatectomies will be done in a lot of large volume centers by either of these 2 methods. But I think what's important to have is there should be some way of selection. Yeah, that's one thing. But actually, there should be some way. See, Korea is completely different. I think you can have a lot of patients having complications in India without anybody ever knowing it until it comes out in the newspaper. I think we need to go step by step and at least get the expertise in the large volume centers before everyone tries their hand at it. Even now, I think even for the near future, open donor hepatectomy would remain the gold standard. I think definitely for the right side. So I think that the progression should be open to robotic/laparoscopic rather than directly going to robotic or laparoscopic like we do with cholecystectomies these days. I think that's what I would say.
I don't think it can be summarized any better than that. Dr. Vinay, would you like to add anything or?
I think the primary consideration is donor safety rather than donor comfort.
Yeah, that's true. Sir, I think we got 2 hours.
It's a wonderful discussion, I should say, and I mean, it's quite absorbing, and it's nice to see Srinivas Reddy participating in a big way. I generally don't see it much, and it's nice to see Vinay also there till the And thank you so much, Vinay, Srinivas, all of us. And we shall see again in coming Friday with another interesting area. Ashwin?
Yes, sir. Yeah. So, and thank you so much, Goja, Rajesh, and Dr. Vinay, and Dr. Reddy, as always. Thank you so much for the support and for being here for 2.5 hours now. With this, we'll close the session and hopefully meet next week.
Thank you. Thank you. Thank you.
Thank you.